Welcome, dear friends, viewers, colleagues, and my dear students on your favorite source, MuniMeterHealth. I'm Dr. Jaitly from New York, your cardiologist, and here once again on a brand new subject and brand new video and a topic. We'll discuss what is stage A heart failure and how can it be prevented or preempted to progress further. Very important, right? So let's identify the problem, the magnitude of the problem that exists in the United States alone. Well, first of all, understand that used to be barely about 5 to 6 million people only, I'll put million, who were diagnosed, say, between the last decade, I would say. Now it has increased to about 6.5 million people. Okay, as of the census, which was completed only a couple of years ago, 2014. So that's one. Then there has been an increase in mortality despite all this awareness that's going on, 250% in the past 20 years. So almost in 2 decades, you have jumped the mortality and the morbidity to 150%. Then there's a recurrent increase in hospitalization of the recurrent heart failure. So hospitalization has gone up, as you see. And the more the patient gets admitted, they come back with worse EF. So the ejection fractions are also dropping with each hospitalization, if you will. So having identified these problems, let's understand where are we today. Well, the ACC and the AMA guidelines clearly say that one, we need to ascertain whether these patients have some risks. Well, first of all, understand what the risks are. You have hypertension as a risk. You have a diabetes patient as a risk. You have a patient who is a smoker who is a risk, and obesity, and the list goes on. Patients who have high cholesterol, patients who have atherosclerotic cardiovascular disease, or even family history. Now, these are the patients who really belong to stage A, where the structural disease has not occurred, but they are prone to develop structural heart disease. So stage A is where there is no disease, but you identify these risk factors in these patients, and they're called cardiovascular risk factors, if you will. Okay, so that's stage A. And stage D, which is D as in David, that's how it progresses, where actually it's advanced heart failure. So and B and C, of course, you have reduced heart functions, and or if you have already some structural disease. So stage A is the time when you need to catch these patients early, so this way you can identify and actually offer a great deal of preventative approach. So that's my nutshell advice. So my clear the goal of these small video chapters is primarily one, to enhance patient education, to improve medical education both for primary care and cardiologists, because I think the brunt of the entire pressure or the real sense of preventive care lies in the hands of general practitioners and primary care all over the world, because that's where the GPs and the primary care should come in play, because they are seeing all these patients, the hypertension, the diabetics, the smokers, the obesities, and of course the likes. So they are the ones who can refer these patients directly to the cardiologists and offer various testings. Now, what are the possible testings that you can really do? Well, number one, you need to have an ECG, obviously. That'll define whether there is an LVH pattern in these patients. That could be immediately a quick screening tool if these patients are, or they could be having silent ischemia. There's some abnormality, for instance, like significant T inversions that can exist in a diabetic patient. So obviously you're screening these patients right there. Then target organ damage could be assessed by proteinuria and urinalysis, as simple a test like that. And if you do an echo, obviously, which is more specific for LVH pattern, because sometimes LVH may not be seen on an ECG. It's only a 50% sensitive and specific, as we know. Echo is 100% sensitive, obviously, because it'll define the left ventricular hypertrophy in a two-dimensional echo. Valvular problems can exist. So you can see LVH, you can see valvular problems. If those have already occurred, that's structural damage right there, and that is stage B almost. So there also you can still prevent. Again, patients may be asymptomatic. And then you have an asymptomatic LV dysfunction. We call it ASLVD. Now, these are very, very important scenarios where the ejection fraction could be just borderline 50%. And these are called heart failure preserved ejection fractions. Okay, so these patients, again, they may they may float around in the community with no symptoms whatsoever, and next thing is their morbidity and mortality has worsened. So in fact, the ACC and AHA, they have already looked at some of the very early stages of heart failure, preserved ejection fraction individuals, where the mortality and morbidity is higher than the patients who do not even have asymptomatic LV dysfunction as yet. So the question here is, how do you identify? So again, an ECG and an echo, and of course identifying other cholesterol profiles like the TC and the TG profiles can be assessed as well. Now once you do that, then obviously the next question idea is not to just diagnose, but also therapeutically offer an option to these patients. So then you start putting these patients on either ACE inhibitors, or you can start with them on ARBs. Control their pressures better, so obviously control of blood pressure to an optimal range. So you want to bring down the systolic pressures. Now recently there has been some confusion about the guidelines about the systolic blood pressures, but I think I would still say lower is better. So the lower the pressure that you can achieve in these patients, I think it's very helpful both for cardiovascular disease and to prevent not only cardiovascular disease but also the CKD, we call it, the chronic kidney diseases. So these patients will not progress to these because they are the ultimate causes of morbidities and mortalities. And likewise is also true for the CVAs, because the stroke incidence is also reduced in these patients if their systolic is less than 120, if you can achieve that. So having said that, now you got to maintain these patients. So ACE and ARBs, those are the two top drugs. Sometimes beta blockers are used, and beta blockers have a great cardioprotective effect, as we know, and they can really help both in systolic as well as diastolic dysfunctions that will develop down the line in these individuals, especially who are at high risk. So it's very, very crucial that we follow these as guidelines to treat stage A and sort of preempt the progress of the heart failure in general. Okay, and counseling, very important. We gotta give them proper counseling, both for diet. We got to talk about the vegetarian diet preferably, and of course rich in nuts, if you will, grains. There are plenty of proteins in there. A lot of the question always arises, oh, by the way, vegetarian diet does not offer proteins. No, it's incorrect. If you get the nuts, the grains, and the legumes, you're all okay with the protein intake, so you don't have to worry about that. In fact, Mediterranean diet has been the choicest diet to prevent the progression of cardiovascular disease. So that's the diet alone. Exercise, now ACC recommends that 30 minutes 5 times a week. If you can exercise, that should be enough. And we are talking about aerobic exercises, so all you have to do is just simple walking. You don't have to really beat the treadmill, but just do the aerobic, plenty brisk walking, 30 minutes, 3 to 5 times a week, preferably 5 times. Third, of course, weight control is very important, and control of your blood pressure and diabetes. Do not forget to check your A1C quite often. Do not forget to check your blood sugar quite often. And then, of course, your blood pressure. So you have to check your blood pressure as well. So these are your common parameters where you can really prevent a stage A to travel to become stage D eventually, because that's the goal of the disease. And you want to prevent that. You want to preempt that and keep it at stage A, where there is no structural involvement in the heart at all, and your echo is still normal in those individuals. So again, once again, students, residents, fellows, my dear colleagues, and of course, including general practitioners and cardiologists, my goal through this small short video is mainly to prevent further progression of the disease, and therefore offer patient education in one way, and then do a medical education as well. So this way we are more knowledgeable, and therefore we can handle treat our patients much better. So that's our interest. And once again, thank you for joining on MuniMeterHealth. If you like this video, don't forget to press the like button, and of course do ask me questions, suggestions, and we make it a point to write back right away. Again, watch us on various platforms. We are MuniMeterHealth. I'm Dr. Jaitly from New York, your cardiologist. Thank you again for your attention.